Good afternoon. So today we will be discussing respiratory alkalosis. So we take a hypothetical example that suppose the pH is 7.51, PCO2 is 30, HCO3 is 28 and PO2 is again say 40. So alkalosis definitely is there. CO2 is moving away from your pH, so the problem is respiratory, it's washing out, so it is respiratory alkalosis. Compensation, it's slightly higher normal, right? So compensation is not there, but you have severe hypoxia. So how to evaluate a patient who has respiratory alkalosis? So again, as we had 7 T's, we again start with some T's here. So again, some tumors of your posterior fossa can result in stimulation of respiratory centers because of irritation. So tumors are not only suppressants, they can be stimulants too. So any tumor can give rise to high respiratory drive, wherein your CO2 will be washed and patient may land up into respiratory alkalosis. Then a high basal metabolic rate, so your TSH is low. A low TSH, profoundly thyrotoxic patient can present to you with respiratory alkalosis, right? A patient who is having severe or high fever, temperature which is high, again the basal metabolic rate. So what happens with basal metabolic rate is a set, they change the set point of these central respiratory drives, right? Then you have your hypothalamus. Hypothalamus is a part of your limbic system. So any pain, severe pain, any fear, any anxiety. So what happens with hypothalamus is that hypothalamus acts directly on these centers as well as on these centers too. So the problem is not in the centers per se, the problem is with your limbic system. It's not even a problem, it's an exaggeration of normal emotions. So you have pain, you have fear, you have anxiety, you can yourself experience that your respiratory drive is high. So that is your beautiful hypothalamus working on. Then you have toxins. In toxins you have drugs. In drugs, the most important drug which increase your respiratory drive is aspirin. The second drug which increase your respiratory drive is nicotine. The third drug is methylxanthine, which you use in your COPD patients. So aspirin, nicotine, methylxanthines, they can cause respiratory alkalosis by increasing your respiratory drive. So these are 5 T's: tumor, TSH, temperature, hypothalamus and toxins. So 7 T's in respiratory acidosis, 5 T's in your respiratory alkalosis. Then you have profound gram-negative septicemia. In gram-negative septicemia, you have high concentration of lipopolysaccharides, and these lipopolysaccharides, they go to your central respiratory drives, medullary respiratory centers, and increase your respiratory drive, right? Then you have hepatic failure. A patient who has hepatic failure will have high levels of ammonia. Ammonia is a potent stimulator of your respiratory centers. So definitely these patients will land up into respiratory alkalosis because of your high respiratory drive. Last but not the least, a patient who is pregnant. Pregnant patients have high progesterone level. High progesterone level. Progesterone again is a potent stimulator of your central respiratory groups. So these patients will land up into respiratory alkalosis. So how do you treat? Suppose you have a tumor, so you use steroids and surgery. Suppose your TSH is low, so you use antithyroid drugs such as methimazole or propylthiouracil. If your temperature is high, your core body temperature is high, so you could use cooling. For pain, fear, anxiety, you use your mind to treat, right? For drugs, for nicotine, definitely you have to withdraw nicotine. For methylxanthines, again you have to withdraw methylxanthines. For aspirin, again, if you have high dose of aspirin, you use NaHCO3. Right? So in barbiturate overdose causing respiratory acidosis, we use NaHCO3, and in aspirin overuse causing respiratory alkalosis, we use NaHCO3. So just two indications in both respiratory problems of use of NaHCO3. Right? In pregnancy, it's a normal component. We don't use anything. In gram-negative septicemia, you use good antibiotics. For hepatic failure giving rise to high ammonia, you use rifaximin, you use lactulose, you use L-ornithine, L-aspartate, and conventional treatment. Now, as we discussed in our last lecture, whenever you have consolidation, ARDS, pulmonary embolism, or pulmonary edema, all these will cause low PO2. This low PO2 will stimulate your central receptors, right? And your respiratory drive will increase. So patient will present to you with respiratory alkalosis initially. So always remember, initially respiratory alkalosis will be a component of consolidation, ARDS, pulmonary edema, and pulmonary embolism. You know, consolidation, mind conventionally says that it has infection. So infections means metabolic acidosis, but no, just remember your flow diagram for metabolic acidosis. In metabolic acidosis, infection is not coming. So most of these patients, you go to your ICU and see patients of consolidation, they probably will be having either respiratory alkalosis or respiratory acidosis. A patient who has lots of fluid in the lung will have a respiratory alkalosis, and then it will land up into respiratory acidosis. Then the patient will get into lactic acidosis. So initially the problem is always respiratory to start with, and then the metabolic component takes place, right? Then the other thing is your central nervous system, that you have increased intracranial pressure. So how do you decrease intracranial pressure? Either you take out your scalp, so give rise to your expanding brain some space, or you put a tube wherein you can drain the CSF, or you decrease your blood flow. How to decrease your blood flow? You know, respiratory drive, if it is high, your CO2 is washing away. A low CO2 is a stimulus for decreased blood flow into your brain. So suppose you have a patient who has increased intracranial tension because of a tumor, or you have hemorrhage, or you have brain edema because of any cause. You want to decrease the edema. You are using 3% saline, you are using mannitol, but you want to do something acutely to prevent herniation. So you intubate the patient and hyperventilate. The moment you do hyperventilation, your CO2 gets washed away, your blood flow will decrease. The only problem with this is patient can land up into stroke. The only problem is that you are decreasing the blood supply to your brain. So you can land up into stroke. So you have to judge your patient wisely, and this is not for chronic use. You can't, endlessly hyperventilate your patient. This is just for acute settings to prevent your herniation, right? The other thing is, it can be an iatrogenic problem. You have put your patient on ventilator, but you are not monitoring his respiratory rate. If you are not monitoring the respiratory rate, so you may be, iatrogenically washing out the CO2. You are washing out your CO2, your blood flow to your brain will decrease. Patient may land up into neurological catastrophe, right? So you have to monitor respiratory rate of a patient when the patient is on ventilator. On ventilator, suppose your CO2 is coming out to be low, that means you are iatrogenically hyperventilating your patient and putting patient into respiratory alkalosis, right? So this finishes our respiratory alkalosis, and we finish off with our ABG series of lectures. Thank you so much.